Zaterdag 11 oktober 2025 spreek ik in het St. Mark's ziekenhuis in Londen op de Fistula Awareness Day. Een nieuw initiatief voor fistelpatiënten. Misschien hebben de Nederlandse fistelpatiënten ook wel wat aan deze lezing, dus hierbij vast een preview van wat ik daar ga vertellen. Groet uit Tilburg. It's not always clear what the exact difference is between a fistula and an abscess. An abscess is a relatively large, red and swollen area near to the anus and is usually increasingly painful. For an abscess, many people often have to be admitted to hospital in order to perform an emergency operation to get rid of it. Some people will then remain to have a small hole or pimple next to the anus that will produce small or sometimes larger amounts of smelly fluid. The pimple may hurt once every while and can become an abscess again. Some people will frequently have abscesses, whereas others will only have the small hole that can be very irritating and painful. Because one condition will lead to the other, many patients feel that they have not been treated right and that the operation they had for their abscess may be the reason they now have a fistula. Unfortunately, about 1 in 3 people who have an abscess will turn out to have a fistula afterwards, and there is nothing the surgeon or doctor can do to prevent this. Many people ask, what causes fistulas and abscesses? And to be entirely honest, we are not 100% sure. Since the past century, most doctors believe in the cryptoglandular theory, which is based on the presence of very small glands that we can find using microscopic examination of the anus. In broad lines, the theory is as follows. We are not entirely sure why there are little glands around the anus. Possibly their use is to lubricate the anal canal so it is easier to pass stool. Like any gland in the body, these glands can get obstructed, either by little chunks of stool or possibly by the material they produce. If one of these little glands obstructs, there is nowhere for the contents of the gland to go. Because of this, it will swell and bacteria can grow in it. The content of the gland will increase and will slowly become more and more infected. By now, the patient's bottom will be swollen, red and sore, and the swelling will become bigger and bigger. By now, we call it an abscess. If left untreated, most abscesses will open up to the skin, leaving a hole and erupting the vile, stinky contents of the abscess. The pain and redness will very rapidly disappear. Often an operation is done to speed up this relief. After the abscess is what we call drained, it will quickly decrease in size. The inflammation and redness will hopefully disappear. In most people, the abscess will fully heal, but unfortunately in some, the connection between the skin and the anus will remain. This remaining connection is what we call a fistula. Many people ask what they can do or what they could have done to prevent their abscess of becoming a fistula. Unfortunately, as far as we know, there is nothing you can do. Please don't believe anyone telling you a different diet, more exercise, expensive supplements, or better hygiene will do the job, because they don't. Maybe the most important thing to realize is that fistulas cannot be prevented by packing the wound that was created during the operation with cotton or gauzes. Even though extensive research shows that this packing of the wound only hurts and costs a lot of time and money without doing any good, still some surgeons prescribe this type of treatment and we all should be very critical about it. People often confuse ingrown hairs that cause a nasty infection with anal fistulas. This type of problem is called pilonidal sinus or cyst and is usually located a bit higher up between the buttocks, near the top of the crease where the cheeks meet your lower back. Whereas the opening of an anal fistula is located around or near the anus. Even though the cause and location of these two problems are completely different, it is sometimes difficult to tell them apart, even for some GPs. A surgeon, however, will be able to spot the difference very easily because we see them regularly. Let us focus on the different types of fistula we know. Surgeons usually try to tell the difference between simple and complex fistulas. We call a fistula simple when it can be safely cut without doing too much damage to the muscles that surround the anus, in order for the patient to have good continence after the operation. Simply cutting the fistula, or as we call it, a fistulotomy or a lay open operation, is the oldest fistula operation we know. If you want, you can see what this operation looks like when you follow this QR code. Beware! The images are very graphic, however, in my opinion, you have a right to see the operation. Without going into too much detail, this operation is very effective. It works almost always, but unfortunately it cannot be used in every patient with a fistula. The reason is that in this operation not only the fistula is cut open, but also part of the sphincter. Sphincters are the muscles that close your bowel and make sure you do not have accidents. Imagine a couple of elastic bands tying off a fluid-filled plastic bag. Many patients are frightened by the idea of cutting a part of this important muscle, so let me explain to you why it is often possible to do so anyway. Sometimes sphincter muscles can be safely cut. Imagine your bowel as an upside-down plastic bag filled with water. Imagine the sphincters being a group of elastic bands securely closing off this bag of water. If I would cut only one of these elastic bands, nothing would happen. The bag would still be safely closed. If I cut a second elastic band, the water would not flow out. However, it is very likely that a small drop of water may spill out from time to time. However, if I cut the very last elastic band, nothing will stop the flow of water and the water would spill out. Of course, a real bowel is seldomly filled with water, so reality is somewhat more complex than my little cartoon. So briefly, in some fistulas it is possible to cut the fistula without doing too much damage to the sphincter, and in others it is not. Your surgeon can only properly assess this using either an MRI or an endoanal sonography. Making this assessment is the first step in deciding what treatment is best for you. As a matter of fact, the most important classification we use looks exactly into this. Let me explain. Let me explain to you what sphincter muscles are and why this is so important for us. We all know where the anus is located. Directly around the anus we find the inner muscle. It is called the internal sphincter. This muscle is a little bit like an automatic door. It opens and closes without you thinking of it. In everyday life, this muscle tightens automatically when small amounts of gas, mucus or stool enter the rectum. The outer muscle, or external sphincter on the other hand, is like a strong gate of a castle. It has to be closed actively and is able to withstand much greater force. In everyday life, this is the muscle you squeeze actively when you have to hurry to reach the toilet in time, or when you're trying not to pass wind when you're in a store at the till. Now imagine these two muscles as two cuffs that surround the anal canal. This is the way the internal and external sphincter are located around the anal canal. Now the method we usually use to describe fistulas is to describe where the fistula is in relation to these muscles. The first and most simple fistula is the subcutaneous fistula. It runs under the skin only and can be cut without damaging any muscle at all. A little bit more serious, however still considered to be a simple fistula, is the intersphincteric fistula. This fistula runs through the inner, but not the outer muscle. When the fistula runs through the outer muscle, we call it transsphincteric. These fistulas can be either simple or complex, depending on the person who has it. For instance, we may consider a similar fistula simple in most men, but complex in women, especially when it is located at the front. Depending on how much of the outer muscle has to be damaged in order to heal the fistula, we call these transsphincteric fistulas low, mid, or high transsphincteric fistulas. High transsphincteric fistulas are always considered to be complex. So your surgeon will make a very careful assessment of the risk of having leakage or accidents after the operation and discuss this with you. Some people will gladly take the risk, others will not want to take any risk. Especially if earlier attempts to cure the fistula have failed, many people tend to accept more risk in favor of a bigger chance of healing. Even though it may be hard to imagine, some people are so bothered by their fistula that they will gladly accept a risk of leakage or small accidents. It is very important to have a good talk with your surgeon, so that you understand the risks and benefits of an operation, and so your surgeon understands what is important to you. Very often it is necessary to have some form of imaging, and your surgeon should always be able and willing to explain to you why he or she is or is not using MRI or sonography in your case. Obviously, for fistulas in which a fistulotomy is not possible, or in which you don't want your sphincters cut, there are very many operations available. We call these SPP, or sphincter preserving procedures. In short, these are operations that aim to heal the fistula without cutting any sphincter. Many of these techniques will be discussed today, so I will not go into them now. Just remember that operations that have less impact, and by that I mean smaller or no wounds, less pain, less risk of decreased continence, will have a lower chance of healing, and that operations that will do more damage and will hurt more, unfortunately have the highest chance of success. Let me finish this talk by giving you some general advice. Make sure your surgeon makes a careful assessment of your fistula to see if simple treatment is possible, as well as to select the best treatment for you if it isn't. Make sure your surgeon takes enough time to help you understand the risks and chance of success of the operation he or she proposes. Make sure to ask about alternatives, and finally ask about their experience with the technique. Not experience in general or what literature says. Ask them specifically about their experience, for instance by asking how often they do this type of operation. Now, thank you very much for your attention, and thanks to Mr. Tozer and Sanan for inviting me for this special day, and I hope to have contributed to your basic understanding of a very complex problem. I hope you enjoy the rest of the day, and I look forward to meeting you again in future. Thank you.